Good afternoon. Thank you for coming this lovely afternoon. I mean, I love the windows because we get to see outside. This is our women's education or health education series. So this is our second event that we've had. So if this is your second time attending, thank you for being a diehard fan. If this is your first time attending, you're going to become a diehard fan because this is my favorite event. Very fun. We have a little bit more space in this room than we did last time. And they upgraded us and gave us like a little reception area, which I think is kind of nice and maybe gave us an opportunity to connect ahead of time. I think half of the things we learn are in the conversations we have on the side. So this is a space for you to have those conversations in a safe environment. So hope you've had a chance to be able to do that. All right. We, Providence Swedish, are the leading organization for women's health care in the Puget Sound. I can say that with 100% confidence. And we take a lot of pride in that. And our vision is that we deliver more. We give you the care that you need for every stage in your life as a woman, right? So from adolescence to menopause, from menopause to healthy aging, we want to be able to provide all of that for you as a comprehensive service in one place. And so we're building a model, and the model prioritizes prevention, specialty care, and whole person wellness. And so when we think about whole person wellness, what's whole person wellness? It's primary care, it's mental health, it's cardiology, it's urogyne. And to be able to get those services all in one place, that is our goal for us, for women. And for too long, I would say far too long, I don't believe that our unique needs have been addressed by our community or really even our nation. I would say we have been misunderstood, we've been overlooked, we've been understudied, underfunded, and that continues today in 2025, which is mind-boggling to me because we are 50% of the population. So this is our time, I think, to build an environment, to build a space, to build a series where we can learn from each other. So at Providence Swedish, our goal is that we will learn by listening, so listening to you all, listening to each other, and by delivering care that is appropriate, equitable, and inclusive. And since 2018, thanks to the vision of our physicians and the generosity of our donors, we developed the Swedish Gynecology Specialty Center. And it is a place where pelvic health, menopause, and sexual health can all be addressed in one location. And so we are expanding the focus of our Swedish Gynecology Center to include cancer, brain health, and ensuring that women have access to all of the care that they need. So these things don't happen by chance. These visions don't get created overnight from nothing. They require people and they require commitments. And I will say that the number one person I think about when I think about the ideas and the thoughts around building a women's program comes from what I would say our founding mother, Dr. Tanya Sorensen. So Tanya is amazing. I look up to her as a leader. She has driven this for Swedish, and I have been by her side the whole way. So I cannot thank you enough for your vision because that is what has got us to where we are here today. So thank you, Tanya. So this event is also made possible by our amazing task force, which is filled with members and donors who have really shaped this series. This task force gets together, they talk about what we'd be interested in hearing and learning, and then they develop the programs that you get the opportunity to see. So I'd like to acknowledge our task force members. So Meredith Beatty, Pat Hackett, Jane Halligan, do a wave. Jamie Shanks, let's see, Carol Westland, and Becky Wilcox. So thank you all for your work. We should all be thanking them. And then a special call out to Lori McDonald Johnson. She is not here today, but she sent us something special. So the wine at your table was provided by Lori's winery, Stellar Wine. So please enjoy that and maybe have a second glass. I want to do a special recognition to Dr. Diana Perkinson. Where are you? Oh, there you are. Thank you, thank you, thank you. So Dr. Diana has recently retired. She has a decade-long legacy of serving our community and serving women. Her compassion and her clinical experience is something that is to be revered. And so thank you, Dr. Perkinson, for your service. And then thank you for bringing your knowledge and your inspiration to us here at the foundation. Thank you so much. All right. We have several physician partners that I need to thank. So Dr. Luba Fultz, Dr. Fultz, maybe. Oh, there you are. Dr. Julie Lamb. And Dr. Kimberly Morset. So thank you. And to our donors, thank you so very much. None of this would be possible without you. It is your generosity that created the Swedish Gynecology Specialty Center, and it is your generosity that is helping us to expand the work that we're doing there. All right, now for today's topic, we will be hearing from two physicians who are helping lead the way forward. The first, Dr. Naomi Diggs, who is an internal medicine physician at Seattle Medical Associates, and second, Dr. Renea Vasavada, who is an OB-GYN. Hopefully I said that right, because you're laughing. I said it wrong? Sorry, you'll have to come and do the introduction again. So she is an OB-GYN at our Swedish Gynecology Specialty Center. So with that, I will hand it over to our host, Manda Factor. Manda, who is known for her engaging interviews, yes, and inspiring, interesting conversation. So thank you so much for taking the lead.
Nice to see you again.
Thanks. See you again, Tim.
Thank you again. It's really great to be here. This is such an important topic to me as a woman of a certain age. And I'm really glad that this conversation is coming to the forefront. It's long overdue. So thank you for being here. And I'd like to welcome to the stage now, Drs. Diggs and Vasavada. Thank you both so much for being here today on this lovely fall day. Fall's my favorite season. I'm sorry I keep bringing it up, but I'm super excited about it. So thank you both for being here. We're going to learn a lot. Like I said, my goal is to learn something new every day. So let's go ahead and dig in if you guys are ready. Sure. I will have to say, we enjoyed our lunch upstairs, all the way upstairs. And we looked at each other and said, wow, this is a lively group, isn't it? So thank you. It was great to hear the laughter and the chatter, and I hope you really enjoyed your lunch. So let's just start with a softball for both of you. Dr. Vasavada, I will start with you. What inspired you to pursue your field, and what keeps you inspired to continue?
Well, I want to start out, I'm amongst Seahawks fans, but my Bears did win this, this weekend as well, against the Cowboys. So I've been an OBGYN for over 20 years. And to be honest, most of my career has been mostly OB focused, up until about 5-6 years ago. And I had more and more women coming to my office asking for menopausal hormone therapy. I'm like, I should learn a little bit more about this because we don't get a lot in our training. And so I joined the Menopause Society, started doing some research, started doing some, just kind of reading. And at the same time, a lot of weird things were happening to me. And I'm like, And I'm reading, and I'm like, And I'm like, how old am I again? And I'm like, wait a minute. And, when a patient comes to my office now, and she looks at me and she's like, I'm having X, Y, Z, and I think I'm going crazy. And I'm like, yeah, girlfriend, I hear you. Because I know what it feels like. And the menopausal transition, and we'll talk about the difference between perimenopause and menopause, affects every woman differently. We have classes at Children's to go over puberty. We have books. Judy Blume's written a lot about it. We don't have a lot about menopause, and it's something we don't talk about. And every woman's journey is individual. And so my passion is to help women, guide women through this transition so that, they can continue to live a very healthy, vibrant life.
And Dr. Diggs, what
So-
inspired you to your field?
So I'm an internal medicine physician and have been a part of Swedish in some respects since 2012. For a long time, I worked on the hospital side, so taking care of sick, hospitalized patients for short stints, people who had hip fractures, people who had strokes or heart attacks, cancer complications. And then several years ago, I thought, I really want to work upstream and get to know people for longer periods of time and help them stay well at every stage. The reason I love internal medicine is it's menopause, it's depression, it's osteoporosis, it's heart disease, it's wellness.
It's a moth.
It's a moth. It's not a bat. I thought it was a bat when I first came in. So the full spectrum of health from really adolescence. I mean, I take care of 17-year-old children of my patients all the way through my oldest patient ever was 107. So I love being able to care for women and men. Actually, I take care of both at every stage of their lives.
Why do you think our moms and grandmas did not talk about this? I mean, it really is something we're embracing now, but it was almost like taboo. No one wanted to talk about it.
Well, so I'll say one thing is that there are more women physicians, right? And so there's more of us who have had children, have gone through menopause, who actually, there was a great New Yorker article earlier this year about menopause, and it has been talked about, but it was talked about by a different audience, right? We, put women on high dose hormones and high dose benzodiazepines and just sort of left them. It was how medicine was practiced in a really different way. I think now the culture has changed, and I think frankly, having women physicians as your partners in healthy aging is a big, big fundamental change of why we are able to talk more openly about all things in our wellness.
And how do you guys create a safe space for women to feel comfortable to talk about these things?
Being open, listening to them. Women today have multiple inputs and have a lot to juggle. And sometimes it's just a matter of hearing them and being that, just sitting back and let them tell their story and, not necessarily, just basically just listening and just making it as individualized as possible because every single woman is different.
Let's dig in. So menopause is not a one and done deal. It goes through the decades. So for those struggling, going, gosh, is this normal? Am I normal? Tell us just basically what happened starting in your 30s or 40s and then 50s and beyond.
So this is a natural transition. It all has to do with eggs. And as most people in this room know, women are born with a set of eggs. And as you age, slowly and gradually, those eggs get used up. And so in your 30s, your 20s and 30s, prime baby making time, technically speaking, from a biology standpoint, those eggs are pretty good. Every month, you get a signal from the brain, goes to the ovary, says, okay, egg, let's start developing. As that egg develops, your body starts making estrogen. You ovulate, your body makes progesterone. You get pregnant, you don't get pregnant. If you don't get pregnant, those hormones fall, it starts again. So it's like a curve. When you hit your 40s, those eggs have kind of started getting used up. You're kind of on the bottom barrel. Some of those eggs, like that signal from the brain goes to the ovary, and the egg's like, yeah, no, I'm not interested this month. Sometimes you get confusion. When you get 2 eggs that ovulate in 1 month, that's fun. You get a huge spike in estrogen. And as you get closer and closer to menopause, you may not ovulate every month. Your body may not make any estrogen. And so the way we characterize it is perimenopause is the 10 years before menopause. And I wish I had a blood test, and I wish I had a machine that I can put someone in and say, hey, when is menopause? And that's part of the problem. It's a backwards diagnosis. So someone can undergo menopause, and the definition of menopause is no periods for a year. And at that point, we are assuming that there are no eggs left. Like your ovary is no longer ovulating, your ovary is no longer making eggs. So if you have a family history of women undergoing an early menopause, you could be 45, and we call that if you don't have a period for a year when you're not on any medications, it could be premature ovarian insufficiency, which is a little bit different than menopause. But after 45, if you go through a year without a period, you're probably in menopause. If you're 49, you could have had perimenopausal symptoms at 39. If you are 55, you could have started at 45. It's very, very different for every woman. And so part of how we tailor our advice is based on where are you in this journey? Are you in menopause? In other words, is your ovary no longer making any estrogen? Or are you in perimenopause where your ovary is making estrogen, but it's kind of wacky. 1 month it could be high, 1 month it could be low. It's all over the place.
Okay, doctor/comedian. Thank you for the levity. So, Dr. Diggs, when do you find most women are asking for help? They're like, I can't take it anymore. Help me.
Well, so, I'm an internist and I'm a primary care doctor. And so women come to me with lots of different symptoms. I've got women in their 30s, and Dr. Vasavada and I kind of laughed about this, who'll come in and say, am I in menopause? Probably not. You're probably tired because you got toddlers, right? They're exhausting. But women will come to me with various symptoms. So we are all being inundated with media. I sort of call it the menopause industrial complex. And some women want to call every symptom is it menopause? And sometimes I say, yeah, could be. What we know for sure is menopausal is hot flashes. So that's often a very common one. I'm soaking the bed, I'm getting flushed. That's a very common reason that people come. The other things that people come to me for, they may not even associate with menopause. It could be increasing in anxiety. It could be depression. It could be decreased libido. It could be, hair and nail changes, weight gain. And so they come with lots of different sort of non-specific. I think rarely do people say, I have menopause, give me hormones, right? It's much more of, I'm not feeling myself. Something's different. What's changing? And like Dr. Vasavada said, the way I practice is to listen and validate. Yes, there may be a medical reason. I want to make sure it's not your thyroid. It's probably not your thyroid, guys. But I check. It's not your thyroid. There's not other things going on. And then really validate the normalness of this life transition, but also say, look, we also recognize that around menopause and perimenopause, it's the peak of, it's a really challenging time, right? Women may be very busy in their careers. They've got children at home or are launching. They may have aging parents that they're caring for. And so the timing could not be worse, right? To have all this pressure. And so a lot of it is validating what symptoms they're having and then seeing what's reasonably possible to treat with medications or not.
And Dr. Vasavada, is it hot flashes normally is that the primary symptom that people come in?
Hot flashes, but as an OBGYN, irregular periods, heavy periods, vaginal dryness, decrease in libido, along with an increase in anxiety, weight gain, brain fog, skin and hair changes. You have estrogen receptors everywhere. And so I've seen plantar fasciitis, I've seen weird eczema. Who knows how it's affecting your body?
But it can be tied back to menopause. Mm-hmm. All right, let's take a step back, bigger picture here. As women get through their 40s and 50s and 60s and beyond, what are the most important things they can be doing? Don't talk about drugs yet, just everyday things.
I'll take that one. So I think of each decade, and I said, I get to take care of teenagers through end of life, which is a joy and a privilege. And I get to, even though I'm myself in my 40s, I care for so many women in their 50s, 60s, 70s, and 80s. It's a gift to be able to say, like, the things that you do now and the decisions that you make and the investment that you make in your health and well-being, oftentimes it actually doesn't pay off until a little bit down the road. And so I think of it like our retirement accounts, right? I'm sort of, if you're, I do this move about 100 times a day. So in my clinic, And I say, guess what this move is right now? You might think I'm just doing some squats, right? It's osteoporosis prevention. This move is getting off of the toilet. This move is avoiding falls and hip fractures. And small things that you do in each decade, habits, high quality sleep, excellent food, and putting good nutrition into your body, cardiovascular health, and then weight training, resistance training. All those things benefit the woman that you are now, but also who you're going to be in that next decade and that next decade and that next decade. And it's so fun to be able to help encourage and validate, like, oh, it's hard to fit those in, right? I can't get to the gym every day. I'm tired at the end of the day and I got to get my kids to soccer practice. But I can do a few up downs, right? I can do Kegel exercises while I brush my teeth. Those are things that you can do now to benefit the future.
A few up downs, is that the technical term?
All day long I do it. I mean, I work out as I work because I can't figure out when to do it elsewise.
What can you add as far as staying healthy through the decades?
I 100% agree with everything that you're saying. Mediterranean diet has been shown time and time again to help with many issues with aging. The other thing that I'm seeing a lot is we have women having babies late in their 30s and in their early 40s. And interestingly enough, one thing that I see a lot of is women having babies when they're 42, 43, and literally afterwards going straight into perimenopause. And so, those women who are in their late 30s and early 40s, whatever you can do after a pregnancy to get your body healthy, in other words, pelvic floor therapy, watching your diet, when you have toddlers, not eating the rest of the mac and cheese, and also having grace. And one of the things I also feel like is it's important. Women put a lot of pressure on themselves. And I see a lot of women sometimes upset that, I had a woman last week who was upset that she had ice cream at her daughter's wedding. And realizing that not everything's going to be perfect. And it's okay sometimes to, have a day where, you have some ice cream. That's okay.
Sometimes I feel like if I didn't eat my daughter's leftovers, I wouldn't eat. That's danger, eating the leftovers from the kids. All right, you mentioned, mentioned briefly hormone therapy. So let's go there. I think that's where the brain goes first when you hear the word menopause. So let's both address hormones.
So part of hormones, everybody goes to menopausal hormone therapy, but there's another hormone therapy as well, which is oral contraceptive pills. And so when women are in their early 40s and going through these swings in estrogen, sometimes, and yes, we do use birth control pills now in women in their 40s, a birth control pill is, the way it works is it basically shuts down your own estrogen and progesterone and gives you a steady amount of estrogen and progesterone every single day. And so that might be a way of managing some of the symptoms when you are in perimenopause and you're going through the swings in hormones. Now, when we talk about menopausal hormone therapy, and notice I'm not using hormone replacement therapy, I like to go into the history a little bit, and part of it, I was a history major in college. And what I like to tell people is, in the 60s, when pharmaceutical companies figured out how to make estrogen, someone's like, you know what, let's give this to some postmenopausal women. They feel great, except for they develop uterine cancer. And so it went from, okay, we're going to give people estrogen to, yeah, let's not do this. Until the 80s and 90s, when pharmaceutical companies started making progesterones. And they figured out, hey, if we give estrogen, progesterone, women do not develop develop uterine cancer. Now, I was a resident in the 90s. I was in med school in the 90s. And I can remember when literally our advice was, we're just going to give it to everybody. It's going to change the world. Women won't get cardiovascular disease. They won't get dementia. And then, as you all know, 2002 ended that. And in the last 20 years, when we look at how we give menopausal hormone therapy, we give it mostly in a patch or a gel form. And the reason for that is oral estrogens, as we found out in 2002, can increase your risk of blood clots because in order to get processed, they get processed through the liver. So the safety has improved because of our delivery mechanism. Progesterone, we now use prometrium, which is actually the progesterone molecule. It's a little bit weaker than some of the progesterones, so hopefully does not increase the risk of breast cancer, but it's strong enough to prevent uterine cancer, which is what we want to do. Sometimes we can do, that's kind of our basics. There's other ones. Duvet is out there, and that's an oral estrogen with SERM, which is like a tamoxifen, so it's kind of an estrogen antagonist and agonist. There are, again, oral. There is a ring you can put in your vagina. So those are the ones for systemic estrogen use. Now, vaginal is a completely different animal. And the reason why is we have low-level estrogen products that are not reabsorbed by the body. In other words, it is safe to use even in breast cancer survivors. And vaginal estrogen can be found in a cream, it can be found in a pill, it can be found in a ring. And that can be used throughout a woman's lifetime and has wonderful benefits.
I noticed you made it clear that you didn't call it hormone replacement. Is this a different way of thinking, or is it just a totally different ballgame now?
So part of it is in the 90s, the pharmaceutical companies called it hormone replacement as a marketing term. You're deficient in a hormone, so we're going to replace the hormone. When you're on menopausal hormone therapy, we're not replacing the estrogen. We're giving you a little bit of extra estrogen to bridge that transition from going through perimenopause, where you have these highs in estrogen, to menopause, where no longer your ovaries making estrogen. You still get estrogen from other parts in your body. You get estrogen from fat cells, and you get estrogen from adrenal cells. So it's not that you're lacking estrogen. You just are lacking estrogen from the ovary. And so the purpose of menopausal hormone therapy is just to give you a little extra estrogen to bridge that gap until your estrogen receptors get used to not having as much estrogen.
All right, Dr. Diggs. Oh, go ahead.
And actually, I was going to ask, so Dr. Vasavada gave a great analogy of jumping into cold water, and I'm going to steal it from you. So will you share it for my patient? Please share. But it was such a great way of thinking about what the medications are for.
So what I tell a lot of women in my office is menopause is like jumping into a cold pool. Initially, your body's going to be in a little bit of shock, like what the heck is going on? But the longer you stay, your body's going to get used to that cold pool. The purpose of menopausal hormone therapy is to build steps. So you can sit on the steps, let your legs dangle a little bit, get used to the cold water, and slowly and gradually get into the pool. With time, your body is going to get used to not having as much estrogen. But the purpose of menopausal hormone therapy is to bridge that gap.
All right, Dr. Diggs, for those, hormone therapy is not an option.
So I'll echo that vaginal hormone therapy is an option for everyone. It should be. I've got women in their 90s on vaginal hormone therapy or vaginal estrogen, and it can help decrease urinary tract infections. It's a miracle drug that should be available over the counter. So separate from the systemic hormone. But some women really cannot take menopausal hormone therapy, whether they've had blood clot risks, whether they've had estrogen receptive cancers, whether they have very high risk of heart disease. There's medical reasons why systemic hormones can be dangerous in certain populations. And so in those women, there are other options that are non-hormonal to treat symptoms like, particularly the vasomotor symptoms, those hot flashes, whether it's low dose antidepressants, SSRIs and SNRIs, different categories. There's actually a newish medication that's a non-hormonal therapy that can be used if hot flashes are particularly bothersome. And so even if hormones are not an option, it doesn't mean that there are no options, but that's something to talk about individually with your physician.
I think this is something that a lot of us struggle with talking about, but you brought it up when you said your ups and downs and the exercises you do while brushing your teeth. All right, so let's go there. Urinary health and pelvic function. Help us.
Super important. Back, when I was doing OB, I used to tell women that, being pregnant is like running a marathon. And after your pregnancy, you need a cool down and you need to stretch. Most of us in the room were not taught that. And so pelvic floor therapy, now I'm seeing more and more women postpartum do it. But for a lot of aging women, we were never taught that that was important. And as you get older, you have estrogen receptors in your pelvic floor. And your pelvic floor, much like other muscles, get weaker, but you can't necessarily see it. So pelvic floor therapy helps train your muscles. Super important. It improves the tone of your muscles, can help with urinary incontinence. It can help with pelvic pain. I read a statistic out there that 25% of menopausal women have pelvic pain. It can help with libido and sex because things can get uncomfortable, especially someone who I just saw was widowed and decided to have intercourse a few years later. And, pelvic floor therapy helped her because her vaginal muscles hadn't been used in a while. And so I am a big fan. What's great now is I've seen so many more physical therapists get trained in pelvic physical therapy. I just went to a conference. There is an online platform for this. My local YMCA even had a session for pelvic floor therapy. You can go on YouTube. There are many, many resources out there.
Anything to add?
No, that's great.
No? Okay, let's move on. We talked about physical. I do want to point out we will have time for questions and answers a little bit later. So if you have a question pop up, save it for that time and we'll get to them. So let's talk about mental clarity. You've already mentioned brain fog several times. Sometimes I can't remember what I told my daughter 10 minutes ago. So explain how we can still stay sharp. Mental clarity. Help. I've said help 3 times now.
So I think, that's a generic, vague concept, right? But we hear brain fog. And I think there's a lot of potential reasons why people have brain fog. We were joking upstairs. We're constantly inundated, right? Our phones are giving us notifications. We don't sleep well. The news cycle, there's just a lot kind of going on in our brains all day long. And then as we age, definitely brain fog can go along with menopause and perimenopause, but even separate from that. And I get a lot of women well beyond menopause who are worried about cognition. It's a thing that we worry about, right? I can't remember where my keys were. I can't remember names. And there's some amount of that's normal, but then there's some amount that's not. And so being able to go to your doctor and really have that conversation, and there's so much fear and there's so much fear really is, I think, a big reason why women don't bring up their questions. And so having a trusting relationship with your primary care doctor, with your OB, with your family to say, hey, are you noticing something? And I often will ask during an annual physical, how's your memory? How are things going there? Does anyone else worry about that? And so really being comfortable enough to bring it up is really the first step to make sure that there isn't something more serious going on.
What kind of evidence is there that mental clarity is connected to menopause? Dr. Vasavada?
Anecdotal right now. We don't have, the studies are more based on dementia protection. We know that women who have brain fog are not at an increased risk of having dementia later. Despite having brain fog, cognitive function tests seem okay, even when you're having brain fog. And, I suspect a lot of it has to do is, I heard someplace that individuals, both men and women, have the most mental kind of flexibility in their 30s, 40s, and 50s. And so I do think part of what's happening with brain fog is occasionally your brain just trying to process all these inputs and make sense of it and kind of sometimes just shutting down so that it can rest for a little bit.
Boy, that moth just loves us.
I'll say too, along the sort of cognitive brain wellness piece of it, and I'm sure you've all heard of Dr. Eisenberg and her incredible center. I love being able to send my patients to Dr. Eisenberg, who are concerned, right? And on some people with brain fog, cognitive concerns are going to have cognitive impairment and dementia. That's a reality. And then there are others who we say, what can we do to prevent that, right? And it's the same conversation we had about, heart health is brain health, right? Those same vessels, the same diet and nutrition elements, that same aerobic exercise are huge preventive, are important for preventing cognitive decline. The other things that we know, and I mentioned it earlier, is really good high quality sleep, right? How many of us are getting restorative sleep most nights. Women have sleep apnea, but often don't snore. And so they don't look like the sleep apnea guy, right? And so, but they may be the sleep apnea lady. And so being able to make sure we're screening for that. High quality sleep, I talked about. The other piece, and I love seeing you all here, social connections, staying connected with people, our children, our friends, our colleagues, reading, keeping your mind active. Those are all evidence-based things to keep our minds sharp throughout life.
And I'm going to add hot flashes. If you're having hot flashes and they're keeping you up at night, then get treatment.
Easy enough. So when we were having lunch upstairs and you guys were chatting down here, I was amazed by how dominated our conversation was by AI and social media. So you just mentioned social connections, how important, but real social connections, right? How are you navigating the whole new world as doctors?
In terms of social media?
In terms of your patients going, hey,
I read this on ChatGPT.
ChatGPT told me I have
To get
this.
pellets.
So number one is to be aware of what my patients are looking at. And I have stayed off of social media, but kind of had to get on because my teenager went on it. And so I kind of watch and see what's out there. I just went to a conference and someone was saying that they chat GPT what's the newest on menopause in social media. I'm like, ooh, that's kind of cool to know. I look at evidence base, and I'll tell people in the office, look, I'm not going to sell you a supplement. I'm not here to sell you products. I'm not selling you testing. I have no financial gain other than giving you the information that I know is up to date.
Dr. Diggs?
And part of being a sounding board, when, as the first pass oftentimes before I refer to a specialist, is knowing what people are hearing. And because I get to talk to so many women and patients at different ages, it's very interesting. I've got certain patients who will bring me cut out newspaper articles, right? And say, did you read this? And I say, I haven't had a printed newspaper in my house. But I love it. And then others will, send me a MyChart message with what they saw on TikTok, right? And so being able to know where people are getting their information and validate that there is, because of some of the lack of trust and openness and access, people have sought out information from wherever they can get it. And some of that information is great and some of it's baloney, right? And my job is to help navigate. And if I don't know, then I depend on specialists and say, I'm going to go and look and read about this. But the evidence-based stuff, it's simple, but it's not easy. So all those things I just said, diet, exercise, sleep, stress reduction, they sound easy, right? We can just burn it off the tongue, but I just told you I can't get to the gym. It's hard. So recognizing that people are getting lots and lots of information from their friends, from social media, from whatnot, and then helping to be a filter of, for you in context of your life, where does that fit? We joked, I've got women who come to my clinic saying, well, do I have menopause? Do I have perimenopause? And I said, do you have any symptoms? Are you concerned? No, but my friends all do. It's and I said, great, I cured you, and you didn't have, nothing was wrong, And so some of it is just validating that we're hearing it so much that we almost feel like, well, if I'm not having those symptoms, something must be wrong with me. And, no, lucky you, you're doing great.
Comes down to communication, right? And talking with people and doctors.
And I was going to say, not being dismissive. There's a lot we don't know. Yeah. And I tell women all the time, hey, this is the information I know on this day and this time. 10 years from now, this could be different. It's important to hear. And, having done this for over 20 years, I remember when the WHI study came out in 2002. I remember the next day, all of the phones going off and our messaging completely being flipped overnight. And I think there's a lot of lessons to be learned from that, listening and hearing. And sometimes, like you said, it's just a matter of just listening, and that's all you need. That's all they need.
I think,
go ahead.
To echo on what Dr. Vasavada talked about, so I trained just 5 years phase shifted after the Women's Health Initiative study and it was essentially all hormones bad forever, right? And the pendulum swung so far the other direction. And it really wasn't until the last 5 years where I said, well, that's not true. And so I've brought the hormone into my own practice and I'm much more comfortable with them. But my entire training in internal medicine was just none, zero, bad, and that's it. So having humility and why the foundation, why it's important to emphasize research and clinical care is so that we can confidently answer these questions, not just for us, but for our daughters and our granddaughters for many, for many years to come. So it takes research dollars, it takes science to really be able to give the best advice to our patients, and that takes funding. And so and as Dr. Waco said at the beginning, women's health has been chronically underfunded, and so being amongst women who recognize the importance of that and see the value, even in our small community here, of how that impacts our own lives and our families' lives, I think is really inspiring.
We're going to open it for questions in just a minute. I know everyone has a busy schedule and we want to be done on time here so you can get about your day. We will have Shiloh over here with a microphone, and I believe it's Laura over here with a microphone. So if you do have a question, get that formulated in your head. Before we do that, though, I just want to ask both of you if you can give us one actionable item today, something easy. As you said, it's not easy. But what is something we can do leaving this room today to make us all healthier?
I'm a big fan of radical self-acceptance.
I love it.
So my takeaway today is I told you all a bunch of things that you should do to make your life better. Give yourselves a break. Enjoy this first beautiful day of autumn and say, you know what, I'm enough. That last 15 pounds is not going to make or break who I am. We get so many messages from the world that we're not enough. And I want your takeaway is that each one of you is enough. And thank you.
I like that advice. Dr. Vasada?
Well, that's interesting because I was going to say, be kind to yourself. Sometimes talk to yourself like you would talk to a friend and, realize that this is a transition. I had a woman tell me last week, she's like, I'm mourning my past self. And I said, why aren't you celebrating the future you? And how many times in your life do you get to be reborn and reinvent yourself? And sometimes it means, this is an incredible opportunity to take a look and see what works and what doesn't work and rearrange things. And that can be exciting. And why not embrace it?
I think that also is good advice in the topsy-turvy world we live in right now. Be gracious, be kind to yourself. All right, thank you both very much. All right.
So thank you so much for being here today. Thank you for being on the panel. My name is Lorna Nealand. I know a lot of you in here. It's so great to see you. And if I haven't met you yet, I hope to do so. I'm Lorna Nealand. I oversee philanthropy for the Women's and Children's Institute, and we are at the Swedish Foundation. The Swedish Foundation is led by Greg Simpson, our only man in the room. Yes, so thank you. And what's wonderful about the foundation is we get to talk to so many of you, and we are encouraged to have events like this. So I'm just really grateful that you're here. My colleagues are around the room. I'm going to ask you to wave. I think that they probably have spoken with you, but we've got the best job in the world here, and so it's really great to have you here. We have members from our Board of Trustees and Board of Governors. I see Kathy over there, and Tracy and others, and Meredith I see, and others. So thank you so much for being here. Task force members, if you can just give a wave again. So thank these ladies. They're the ones who helped guide. And also inviting many of you here today. So thanks to our donors and people on our task force, many of you are here today. And we were able to launch the Swedish Gynecology Specialty Center and programs such as today. And I'd like to just give a special thank you to our lead donors, Pat Hackett, Jane Halligan, and Jolene McCaw. So if you are inspired by what you've heard today, we just have a couple takeaways. And I invite you to join us in advancing women's health, whether it's becoming or referring patients to us, whether it's becoming an advocate for Swedish, and let them know that we care about women through all phases of your life. And lastly, connecting us with others who care about this mission, whether it's you or others who'd like to help work with us at the foundation. So that is the big takeaway for today. We hope you enjoyed today's program, and we are going to send you a survey, and I encourage you to fill it out because that's where you get to tell us what you want to hear next. We're going to launch the series in 2026. We had 2 this year, and we hope to have more in 2026, so I do encourage you to do that. So all I will say is thank you for being here. Swedish is here for every single one of you here and your family, and so I wish you all a wonderful afternoon, and there's only valet here, so obviously chit-chat and know that we might be here for a little bit. And thank you so much thank you so much to our doctors and also Amanda. So have a wonderful afternoon, everyone. Thank you.